Hello, my name is Hugo Turner. I'm a health economics lecturer within the School of Public Health at Imperial College London. Modelling has become increasingly important for the evaluation of public health interventions, such as the use of it within economic evaluations. However, the different types of models have different limitations, and certain model types can be inappropriate in certain situations. It's therefore important to understand the key features of the models used in this area. In this video, I'm going to discuss this and the types of models used in economic evaluations, and going into more detail, the difference between static and dynamic models. Here is an overview of the talk. I'm going to start with discussing what is modelling and how it can be used in priority setting and the evaluation of public health interventions. I'm then going to introduce the key types of models used in economic evaluations, their key features, advantages, and limitations. I'm then going to go into further detail on the differences between static and dynamic models when you're looking at interventions against infectious diseases, and how to decide what type of model to use. And I will then end with some key messages and conclusions. So let's start with what is modelling? Well, a model is a mathematical representation of a system. For an infectious disease, this could be looking at the numbers that are susceptible, infectious, and recovered over time. Expressing the system mathematically allows us to investigate how a system behaves and its key properties, and this lets us make projections of future outcomes, such as what are the long-term benefits of implementing a particular health intervention. Models combine our current understanding of lots of different features of a disease in order to look into its dynamics. This could be things like how infectious it is, how long does the natural immunity last, what is the efficacy of a particular intervention like a vaccine. What's really important to understand here is that they are not a crystal ball that are trying to make perfect predictions of the future, but they're a tool to scientifically look into the dynamics of a disease. I've often seen people say here that models are just randomly pulling numbers out of the air. But really, when they're done correctly, they're the opposite of this, because they're expressing our understanding of a disease and its features mathematically. So in the context of policy making and priority setting, models can assess the long-term impact and costs of different interventions. I've often had people ask me here, why can't we just use clinical trials? Well, there's a number of reasons for this. One is simply the cost. It would be incredibly costly to only use clinical trials for every scenario of potential interest to policymakers. Another issue related to the cost is the timeline. It would actually be impossible to run clinical trials long enough to capture all of the long-term effects of many interventions. There's also ethical considerations. There are certain scenarios where it would be unethical to do a clinical trial on, such as what would happen in the absence of any interventions. And finally, feasibility. There are some scenarios where it's just not feasible to do clinical trials in practice. So although clinical trials are incredibly important, we also will often need modelling to assess the long-term impact of intervention options within economic evaluations, like cost effectiveness and cost benefit analysis. So they are a key part of policy making and priority setting within healthcare. I want to share a famous quote here from George Box, that all models are wrong, but some are useful. And again, this is about highlighting that these models are not trying to give you perfect predictions of the future, but are trying to be helpful tools for informing our decision making scientifically. An important step for these models to be useful for this is model validation. And there are different types of this, such as internal validation, between model validation, and external validation. Due to time, I won't go into these further here, but I make recommendations for further reading on this topic within the supporting file. Now, let's move on to the key types of models used within economic evaluations. There's lots of key terms associated with modelling, like the ones shown here, and this can make it confusing if you're not familiar with them. My advice is to think of these keywords as different classifications or terms used to describe particular features of these models. they're not all mutually exclusive. For the purposes of this lecture, I'm going to classify models as either static or dynamic, but you can classify them in other ways, such as if they're deterministic or stochastic, or open or closed. So there are three main types of models commonly used in economic evaluations. There are decision tree models, Markov models, and these are both static, and dynamic transmission models. Each of these have different advantages and limitations, and it's important to understand these in order to make sure that the right model is being used to answer a particular question. I'm going to give an overview of these model types. I'd like to add here, though, that there are other types that I've not mentioned, as well as variants of these. What I'm going to give is an introductory overview. A decision tree is a form of analytical model in which distinct branches are used to represent potential sets of alternative choices and outcomes. The pathways that follow each choice represent a series of logically ordered alternative events and outcomes. For example, in this figure here, the choice could be having a surgery and its outcomes versus not having a surgery and its outcomes. These modules consist of a series of nodes where the branches meet, and each node may take a form of a choice or probability. The endpoints of each pathway are denoted by these triangular terminal nodes, and this is where the outcomes, such as the costs and health benefits, are assigned. Let's look at this with an example, considering a blindness operation. The decision is taking the operation or doing nothing. The event is the surgery itself, or for the do nothing arm, no surgery. And there's a probability of the surgery being successful and a probability of it failing. And these have different outcomes associated with the terminal nodes. Here, the effectiveness outcomes are being assigned to each segment of each branch, and the outcomes are combined using branch probabilities. So here, the probability of the surgery being successful is 0.6, and the probability of it failing 0.4. So the average effectiveness of the surgery arm takes into account the QALY saved from a successful surgery times the probability of the surgery being successful, and the QALY saved from failed surgery times the probability of it failing. So this gives you a weighted average for this branch. The same principles also apply to the comparator arm, where it's just doing nothing. Now here, the same is being done with the costs. Here, the costs associated with a successful surgery are just the costs of the surgery. The costs associated with the failed surgery branch are the costs associated with the surgery and the costs associated with the patient remaining blind. So this branch has more than one type of cost associated with it. So the average cost of the surgery arm are the costs associated with the successful surgery branch times 0.6 and the costs associated with the failed surgery branch times 0.4. Again, this is about giving you a weighted average. In practice, these models can be much more complicated than this, with more arms and more options than what I've shown here. But the principles are the same. The costs and outcomes are assigned to the terminal nodes, and the branches are combined using the branch probabilities. And then the tree is gradually rolled back to the decision node. An advantage of decision tree models is their simplicity and transparency, and they're going to be particularly useful for the evaluation of events that occur in a very linear fashion. However, these models can only account for relatively simple disease progression, and it's difficult to use them to account for things like disease reoccurrence and remission. So they're inflexible for capturing reoccurring events. Also, as I mentioned, decision trees are a type of static model, so they do not account for the interaction between individuals and populations. And this has implications for infectious diseases, which I'll come on to. Markov models are probably the most common type of model used in economic evaluations of healthcare interventions. These use discrete health states to represent a disease that can capture the consequences of the intervention you're looking at. In this example, the model states are well, disease, and dead. These are mutually exclusive states. So each person represented in the model can only be in one of these at any point in time. Markov models, unlike the decision tree models I just showed you, allow for the movement back and forth between model compartments. Within these models, time itself is considered as discrete time periods called cycles. And how the individuals can move between the health states each cycle is determined by transition probabilities. And these are represented in this figure here by arrows. These transition probabilities can be summarized in a matrix like this. These describe the probabilities of transitioning from each state to any other state in the next cycle. So from time t is the current cycle, and time t plus 1 is the next cycle. If you were in the well state, there would be a 0.6 probability of staying in the well state the next cycle. There's a probability of 0.3 of going from the well state to the disease state, and there's a probability of 0.1 of going from the well state to the dead state. Note that each of these rows has to add up to 1. So if we add these transition probabilities into the figure, we can see what it looks like. So we can see now, if we had 100 people starting in the well state, how they would move through these different compartments. So in the next cycle, 60 would remain in the well state, 30 would move into the disease state, and 10 would move into the dead state, based on those transition probabilities. And then the next cycle, and so on. So in this example, we have 45 people in the disease state by the end of cycle 3. The time spent in each health state for a single model cycle can be associated with a cost or a health outcome. And these costs and outcomes can be aggregated for the modeled cohort over the total number of cycles investigated. Now, if we were going to consider an intervention in this model, we would change the transition matrix for the intervention arm. So now we have a transition probability of going from the well state to the disease state of 0.1 instead of the 0.3 we had before. So this is modeling the effect of an intervention. And now if we were to rerun the model with this lower disease risk, we would see fewer people are moving into the disease state. Now, an advantage of Markov models is that they can simulate more complex disease progression and account for things like reoccurrence and remission much more easier than a decision tree model. However, like decision tree models, these are a type of static model that do not account for the interaction between individuals or populations. Also, when you're using an aggregate level model, these models assume that all the individuals within a particular health state are homogeneous. They're the same, regardless of their past or how long they've actually been in that state. They have the same model parameters. It is possible to address this by using an individual-based model, and this is outlined more in the further reading. Now, dynamic models are a type of model used for infectious diseases. Within them, the rate of transmission is a function of the number of infectious individuals or infectious agents in the population at any given time. And this is being represented here by this formula, this contact rate times the transmission probability times the proportion of the population that are infectious. This looks much more complicated than what I showed with the other models. But really what it's saying is that the probability of an individual acquiring an infection is dependent on the contact patterns of that individual, so how often they do an activity that could get them infected, the transmissibility or the infectiousness of the infection, and the distribution of the infection within the population, so how many people are infectious at that time. So because within these models, the rate people become infected is dependent on the portion of the population that are infectious, the rate will change over time, which is why we call it dynamic. Let's look at this with an example. Let's say there's a disease that's transmitted by shaking hands. The number that will become infected will be based on the number of people that are susceptible times the rate at which they make contact. So here it's the rate at which they shake hands with other people. And this gives us the number of contacts occurring in that susceptible population. This is then multiplied by the probability that someone will become infected if they shake hands with someone that is infected, so the transmission probability, and the proportion of the population that are infectious. So this captures the risk of infection, which depends on the number infected and will therefore change over time and can be influenced by an intervention. Now let's consider adding in an intervention, in this case a vaccine. This will add a new compartment for the individuals that are vaccinated. Now the vaccine is directly protecting these vaccinated individuals. They cannot get infected anymore. However, it also indirectly benefits the unvaccinated susceptible individuals, as because of the vaccination, there are going to be less infectious individuals in the population, and therefore there's going to be a lower proportion of the population that are infectious. So this is going to reduce the rate or risk of infection in the population, as someone that is susceptible, even if they're not vaccinated, will be less likely to meet someone that's infectious. These are known as indirect or herd effects. Those not directly treated or not directly vaccinated can still get a benefit from the intervention. Now there's lots of possible model structures for these dynamic models, and I'm going to show some examples here, but there are many more. You could have susceptible, infectious, recovered, susceptible, infectious, recovered, but with the immunity waning and some people returning to the susceptible compartment, susceptible, infectious, susceptible. So in this case, there's no immunity and people just return to the susceptible compartment and can be reinfected. Susceptible, exposed, infectious, recovered. So in this case, people aren't infectious as soon as they become infected and they move into an exposed compartment for some time. And in this example, we have susceptible, infectious, recovered, and then repeated susceptible, infectious compartments for those that are reinfected. The reason we have this example is because when you're using aggregate level models, everyone within a compartment has the same characteristics. So if you want it so that someone that has recovered from infection has a different transmission probability of getting reinfected or a different level of immunity, you need to add in more compartments. So the model structure for these dynamic models will depend on the disease and the intervention you're looking at. But what we try and do is keep them as simple as possible. So what do they actually look like in practice? Well, I've been showing them with these sort of flow diagrams. But in reality, we code them with what we call differential equations. These look more complicated, but if we look at them in more detail, the terms are just describing how people move between these compartments over each time step. So this ds over dt describes how the number of susceptible individuals changes each time step. Here, that change is just minus the number becoming infected. The change in the number infectious compartment is adding in the number that's becoming infected and minus the number that are recovering. And the change in the number that have recovered compartment is adding in the number that have recovered. So in practice, these models can be more complicated than the teaching examples I've just shown. For example, I'm showing here an extract of some equations for an HPV model, and these look much more confusing. My advice is to remember that these equations are just expressing the rates individuals move between different compartments. If you compare these equations to the flow diagram and a parameter table, these types of models become much easier to understand. So an advantage of dynamic models is that they can account for these indirect or herd effects against infectious diseases. And this is important when you're looking at interventions that impact the level of transmission. They can also simulate more complex disease progression than the decision tree models I showed first. However, they can be often harder to develop, and this type of model can need more data to parameterize it. Also, like a Markov model, when it's an aggregate model, all of the individuals within a compartment are homogeneous. They're treated the same way. And to address that limitation, you need to use more complex individual level models. Now, let's move on to static versus dynamic models. How to decide what model type to use for infectious diseases. So, as I've stated, both decision tree and Markov models are static. And the key feature of these models is they do not account for the interaction of individuals or populations. This is not a problem for non-communicable diseases, like heart disease and diabetes. However, it means for infectious diseases that they're assuming that the rate at which individual hosts acquire an infection is independent of the abundance of infection in that population. So, independent of the number of people that are infectious. So because of this, they can't account for the indirect benefits of interventions, like I showed for vaccination. So, when considering the choice of model for an infectious disease, one viewpoint is that static models are always fine. They just underestimate the impact of an intervention compared to a dynamic model. So they're just giving you a conservative estimate. However, I've also seen the opposite view, with some stating that you should always use a dynamic model for an infectious disease. I and many others would say that there's no one-size-fits-all answer here. The choice of model is going to depend on the question and the context. For example, there are cases where an intervention against an infectious disease will not have a real impact on transmission. For example, this could be interventions that decrease the severity of a disease in infected people, but does not have an influence on how transmissible they are, or interventions that target human hosts where there's a huge untreated environmental reservoir. So in these sort of cases, an intervention is not going to have a significant impact on transmission, and a static model can be appropriate because the indirect benefits are going to be insignificant. So it's not always the case that you have to use a dynamic model for an infectious disease. However, other interventions do impact the level of transmission. This could include things like large-scale vaccination campaigns or mass drug treatment. And in these cases, the static models are not going to account for the indirect benefits of the intervention, and they may not accurately estimate the intervention's overall population level effect. And this is where a dynamic model may be needed. So, dynamic models are important for evaluating interventions that impact the level of transmission. This can occur in several ways for an infectious disease. They can decrease the proportion of the population that are susceptible, like with vaccination. They can decrease the proportion of the population that are infectious. They can also decrease the rate at which the infection is transmitted between an infected and susceptible person. So because static models cannot account for these indirect or herd effects of interventions, they're not always going to be suitable for evaluating interventions that impact the level of transmission. However, this is not going to be every intervention against infectious diseases. There's a misconception that I've seen people make in here that static models will only underestimate the cost effectiveness of interventions compared to using a dynamic model, because they're not accounting for these indirect benefits. And although this can be true, it's not true in every situation. And I'm going to show this with an example. Here we're considering a case study of mass drug administration against ascaris. Ascaris is an intestinal parasite of humans which infects over 800 million people worldwide. The source of the infection is from objects which have been contaminated with fecal matter containing eggs. And we control it using school-based mass drug administration. This is where you provide treatment at a large scale without diagnosing or testing the individuals for a current infection, like shown in this picture here. So, if we were to look at projections using a static model, it would only project a benefit on the children that were directly treated by this intervention. This is shown in this figure here. Here we're looking at the mean worm burden in the population over different treatment rounds. The burden in the children decreases in those that are treated. However, the burden in the adults who are untreated remains constant in the model. However, if we were to use projections using a dynamic model, we would see that only treating the children can actually notably reduce the overall level of transmission at a population level. So this is actually going to benefit the adults even though they are not directly treated. So we can see here the burden in adults is gradually decreasing because there's less transmission in that community and their worms are gradually dying. So in this example, a static model would underestimate the health benefit of treating the school children relative to doing nothing. However, if we wanted to look at other options as well, like should treatment be expanded to include the adults, we would find that the static model would overestimate the benefit of treating everyone in the community versus just the school children, because it's not taking into account the indirect benefits of treating the school-aged children on the population. So it's overestimating the remaining burden in the adult population. So to summarise here, by ignoring the impact of an intervention on transmission, a static model can both under and overestimate the impact of different options and interventions. So it's not as simple as static models only give a conservative estimate. It depends on the disease and the interventions being looked at. When you're only looking at one intervention compared to doing nothing, a static model will provide generally an under or conservative estimate. But by ignoring the indirect benefits, when you start looking at other options as well, they can actually overestimate their impact and incremental cost effectiveness. I would add here that dynamic models are also important to account for other features, such as when interventions cause relevant changes in the profile of infected individuals. For instance, when vaccination reduces the force of infection, it can actually cause the average age at which infection occurs to increase, and in some cases that can be associated with increased risk of disease and morbidity, like with rubella. Also, sometimes an intervention can impact a pathogen's ecology, such as when an intervention results in selective pressure that leads to the emergence of resistant strains or serotype replacement. So, dynamic models can be important in other situations, as well as when the intervention impacts transmission. Here I'd like to highlight a paper which makes recommendations of when to use static or dynamic models under different circumstances. This makes a really important point that in some cases, methods can be used to approximate herd immunity in static models. And again, these really stress that the choice of model depends on the context of your question, including the disease you're looking at, the intervention, and what data is available. I would also like to add here that in cases such as epidemics like COVID, even if the intervention you were looking at had no impact on transmission, such as an anti-disease vaccine that didn't actually affect COVID transmission rates, you may still want to use a dynamic model to account for how many disease cases would be averted over time. Now, let's move on to the conclusions. I want to stress that this was an introductory overview. It did not cover everything about modelling, and the focus was really about the difference between static and dynamic models and why that matters. There are other features or variants of these models that I did not cover. For example, there's other types of dynamic models called Markov chain models, which are different to the static Markov models we discussed earlier. The supporting file associated with this video makes recommendations for further reading and training in this area. So, to conclude, static models are what are most commonly used in economic evaluations of healthcare interventions. And although they can be, they are not always suitable for the evaluations of interventions against infectious diseases, because they cannot account for these indirect benefits of interventions that happen when you reduce transmission. Linked to this, I want to stress that it's not always true that a static model will only ever underestimate the cost effectiveness of an intervention compared to using a dynamic model. They can overestimate them as well. I want to end by saying that there's no one-size-fits-all rule about when you need to use a particular model type. This is going to depend on your research question, such as the disease and the intervention being investigated. To me, what's key is that the methods used and their limitations are clearly acknowledged, and that we're careful not to overuse static models for infectious diseases. Thank you.